Dr. Ken Landa. Thanks for watching. Let's talk about Rexulti, or brexpiprazole. This is a drug that was approved by the Food and Drug Administration in 2015. It's a second-generation antipsychotic, an atypical antipsychotic. It's for the treatment of schizophrenia or as an adjunct, an add-on medicine for people who have treatment-resistant depression. Now, in the second-generation antipsychotic family, we have drugs that are very well known. We have Abilify and Zyprexa and Seroquel and Latuda and Geodon, and we have Invega and we have Vraylar. This drug, Rexulti, happens to be manufactured by a Japanese company known as Otsuka, and they combined their efforts with Lundbeck, which is a company out of Denmark. They're co-marketing this drug. The drug is remarkably similar to Abilify. Question is, second generation a whole lot better than the first generation? That's arguable. Some people, when they first came out, said, hey, these have fewer side effects. Not so sure about that. Well, let's take a look at the dose. If you're going to take the drug, you only have to take it once a day. You take it with or without food. If you happen to have major depression, you can add it to your other antidepressant. Add it at either half a milligram or a milligram a day. Then after a week, you could increase it to 2 milligrams if you need, and even go up to ultimately 3 milligrams if you have schizophrenia. Then you would begin at a dose of 1 milligram for half of the first week. The second half of the first week, take 2 milligrams. And then beginning week 3, you take 4 milligrams. But if you have moderate to severe either liver or kidney impairment, the maximum dose you can take for a major depressive disorder is 2 milligrams and 3 milligrams if you happen to have schizophrenia. It also is important to realize that about 1 person in 8 is born with a defect in one of the drug metabolizing enzymes. And if you happen to be among those individuals, you have to reduce the dose of the drug by about 50%. And if you happen to be taking other drugs can also affect those drug metabolizing enzymes and turn them down, in which case you have to reduce the dose by about 50% if you affect 1 drug metabolizing enzyme. But if you affect 2 drug metabolizing enzymes, you would have to reduce it by about 75%. Now, the 2D6 is impacted by quinine and Cymbalta. The 3A4 is impacted by clarithromycin and fluconazole and other drugs. But on the other hand, if you're taking a drug that stimulates those enzymes, well, then you have to double the dose. So if you happen to be taking St. John's wort, or if you're taking rifampin, you have to take more of the drug. But then you have to realize that when you stop taking those drugs, you got to tell the doctor so that they can appropriately modify the dose that you're taking. And you have to avoid grapefruit juice. You have to avoid Seville oranges while you're taking the medicine, because those are going to change some of those drug metabolizing enzymes. Now, schizophrenia is a major market for this drug. Schizophrenia affects about 2.5 million people. These people have hallucinations and delusions. They have disorganized thinking, trouble organizing their thoughts. They have suspiciousness. They have mistaken beliefs. They feel guilty or anxious. They have little desire to be around other people. And the drug is okay for those people, but the real target is as an add-on for depression. Depression is a major condition in the country. It's diagnosed in about 7% of the people on an annual basis here in the United States. 15 million people over age 18 suffer from depression, and only about 30 to 40% get an adequate amount of relief with the treatment. So taking the Prozac and the Paxil and the similar drugs really doesn't get rid of the symptoms. It may reduce the symptoms, but it doesn't eliminate the symptoms. When you have the symptoms that persist while you're taking an antidepressant, you've taken 1 or 2 antidepressants, and you still have the symptoms, that's what we call treatment-resistant depression. Now, depression isn't just I feel a little bit sad or angry about something. No, depression is a complex condition, and it's associated with finding decreased pleasure in your normal activities, or decreased mood or irritability, and then you have some unhappiness and low self-esteem and worthlessness feelings and pessimism and hopelessness and guilt. So it's a package of more than just I feel depressed. Now, if you suffer from treatment-resistant depression, you actually have depression and now you're under treatment with standard kind of therapy, but you're not really getting better, what can you do? You could increase the dose of the antidepressant. Maybe you could change the drug. Maybe you could add another drug. Maybe you could take a different kind of a antidepressant, different class of antidepressant. Maybe you could take an MAO inhibitor, a tricyclic antidepressant. Maybe you could try some counseling. And for some people, an anticonvulsant, anti-epileptic drug could be used, or lithium in some people, low-dose stimulant. Maybe even thyroid hormone for some people. But now the thing that's catching on is the augmentation therapy. Augmentation therapy with one of these atypical antipsychotics. There are 9 licensed in the United States, but only 3 have received FDA approval for marketing as treatment for treatment-resistant depression. Those are Abilify and Seroquel, and a combination of Zyprexa and Prozac that we call Symbyax. And now Rexulti. There's a question, though, do the medicines really provide significant benefit? Especially when you compare them to the side effects that they cause, the likelihood of atypical muscle movements, tardive dyskinesia, or weight gain, or type 2 diabetes, or now we worry about heart attacks and stroke with the medicine. So let's look at some of the studies that were done. Okay? Let's look at clinically treatment-resistant depression. The people have been on therapy for at least 8 weeks and they haven't gotten any better, taking the Lexapro or the Paxil or the Prozac or the Cymbalta or the Effexor. Let's test them with something called the MADRS. That's a rating scale that we use. Has 10-item examination, 10-item score, anywhere between 0 and 60. These people had an average score on entry of about 27. Now, 175 were divided into 2 groups each of 175 about. One group received a new antidepressant by itself. The other group received a new antidepressant and 2 milligrams of Rexulti. And the people who received 2 milligrams of Rexulti, their score went down by about 8.5 points, as opposed to the people who were taking the antidepressant alone. Their score went down only about 5 points. So there was about a little more than a 3-point difference between the two. That sounds very impressive until you stop for a moment and realize that the final score, instead of starting off at 27, now with the Rexulti combined with an antidepressant, the score was about 19. It was about 22 in the people who were taking the antidepressant alone, and the diagnosis of having no depression is a score between 0 and 6. So we haven't reached that. So let's take a look at another trial. And in this trial, instead of taking 2 milligrams and the antidepressant, now we take the new antidepressant, and some people take the 1 milligram, and some people take the 3 milligram. And what do we find again? We find the same thing. People taking the 3 milligram, they had a reduced score by about 8.5 points. People who were taking the antidepressant in the 1 milligram, they had a reduced score by about 7.5 points. People who were taking just the antidepressant alone, they had a reduction in their score of about 6 points. So when we look at the total score on the MADRS score, people taking the antidepressant alone had a score of 20. People who were taking the 1 and the 3 milligrams, in addition to the antidepressant, had scores of 18 and 19. And again, no depression is 0 to 6. Well, it might sound like it's statistically significantly better. On the other hand, at the end of therapy, these people were still stuck right at the junction of moderate to mild depression. So we haven't eliminated their condition. And as a matter of fact, the whole reason that the antipsychotics might work is they might make you sedated so you sleep better. And the small difference in the score might simply be due to a little better sleep. And that's especially a problem because these studies are conducted by the drug companies, and you have to take their supposed benefit with a grain of salt. But they did another study at the Veterans Hospital Center, the Veterans Administration, and they did a real study. They looked at 35 separate VA hospitals, looked at about 1,500 people who were resistant to at least one antidepressant for 12 weeks. And then for the next 36 weeks, these people received either an antidepressant, a different antidepressant. They received Wellbutrin, or they received Wellbutrin in addition to the original antidepressant, or they were given Abilify. And remember, Abilify and Rexulti are pretty much the same drug. So what was the likelihood of remission? No depression at the end of the therapy. Well, it was only about 25-30% in the entire group. And it didn't matter which of the therapies were chosen. And if we look at the response, so getting somewhat better but not getting completely cured, we find that somewhere between 60 and 70% of the people fell into that group, almost irrespective of which category, whether we're switching off to the Wellbutrin by itself, adding the Wellbutrin to the other antidepressant, or adding Abilify. And Abilify can be substituted for Rexulti. So if we look at the graphs of how the patients responded, you can't see any daylight between them. They all seem to be about the same. Now, if we look at the likelihood of improvement in schizophrenia, well, again, we have the test, and the test is called the PANSS, and it stands for the Positive and Negative Symptom Scale. You can have a score of as high as 210 or as low as 30. These people had a score of an average of about 95. So on the study, they received either 2 milligrams or 4 milligrams or placebo, the people receiving the active drug. They had a decrease of about 20 points versus about 12-point decrease with the placebo. So again, we have a decrease with the drug, but it's not quite as impressive as it would seem. So then let's do another study. Let's keep some of the people on, the people who have responded, let's keep them on the drug or switch them off to a placebo and see what happens over a period of time. See if the schizophrenia comes back. And if we keep the person on Rexulti, 20% of the time, 1 in 5 people who seem to have gotten better get worse right while they're taking the drug. But if we look at what happens with the placebo, half of them are going to have recurrence of the symptoms. So for relatively minor improvement, let's see what the risks are. And the risks are they have a black box warning on the drug. The black box warning says that there's increased mortality in the elderly patients who have dementia-related psychosis if they take the drug, and over a period of 10 weeks, the risk of death increases by about 60 or 70% from their baseline. And that's from cardiovascular disease, sudden cardiac death, or heart failure, or infections like pneumonia. And they have an increased incidence of suicidal thoughts and behaviors, especially if they happen to be less than 24 years of age. Now, the studies only were ongoing for about 4 months, so we don't know exactly whether they're safe after that or what they do to the incidence of suicide. So other warnings and precautions. Well, they can increase the risk of cerebrovascular disease in elderly individuals who have psychoses and maybe have dementia. These people have increased risk of fatal and non-fatal stroke and transient ischemic attacks, mini strokes. And they can have an increased incidence of neuroleptic malignant syndrome, where the body temperature gets elevated and is associated with muscle rigidity and altered mental state, and instability of the blood pressure and the heart rate can sometimes cause the muscles to break down, the kidneys to stop working. And then there's tardive dyskinesia, atypical movements, typically of the face, sometimes of the hands, irreversible movements oftentimes, involuntary movements. The higher the dose, the longer you're on the drug, the greater the risk is. If you happen to have any other kind of disease, maybe increases the risk. So we want short duration, low therapy, and we want to reassess to make sure you really need the drug, because once the tardive dyskinesia symptoms begin, that's a problem. It doesn't go away when you stop taking the drug. And then there are other kind of problems too, metabolic problems. So it increases the blood sugar, causes diabetes. If your blood sugar is normal, 9% of the time it'll be diabetic. And if your blood sugar is borderline, about 25% of the time it's up in the diabetic range. And then there's ketoacidosis and hyperosmolar coma, increases death, increases your cholesterol, increases your triglycerides, and increases the body weight. Short term can cause you to gain about 6 pounds every year. long term, you can have 20-30% gain in weight, but some of the people going to have a decrease, about 10% of the people going to lose about 7% or more of their body weight. You can have inner restlessness taking the drug, 6 to 12% of the people going to have that. Can increase your core temperature, your body temperature, even though it doesn't cause neuroleptic malignant syndrome, it can increase your body temperature still, especially if you exercise or if you're dehydrated or if you're taking certain medicines like anticholinergics, maybe a cough medicine or a medicine to dry up the common cold. And it was recently learned and label change in 2018 that it might be associated with pathologic gambling and other compulsive behaviors like sexual behavior and shopping and eating and binge eating, other impulsive behaviors. The person might not realize that, so the caretaker has to be notified. And when you stand up, it might cause your blood pressure to fall down. It might cause you to faint, especially initiation of therapy or change in the dose. And it's certainly worse, more likely to happen if you're dehydrated or you have a history of cardiovascular disease, you've had a heart attack. You have to be careful of these kind of drugs. And because they can cause this orthostatic hypotension, they can cause you to be tired, and they can also cause you to fall. And then if you fall, you can break something. Then you have other kind of issue. You have to exert a certain amount of caution if you're driving a car, and if you have a history of epilepsy, this lowers the seizure threshold, can cause some Parkinson-like syndromes, cause difficulty swallowing, cause dystonia, especially in young men with spasm of the neck. Sometimes it's so difficult that it makes the tightness so that you have difficulty swallowing. Maybe your tongue protrudes. Usually at high dose, usually relatively soon after you begin the medicine, can cause the blood count to decrease, especially the white blood count. If you're pregnant and you're taking the drug, especially in the third trimester, it might affect the baby. So the baby born then with either hypertonia or hypotonia, agitated tremor, can have respiratory distress and feeding difficulties, can recover in hours to days, or might take prolonged hospitalization. So not for women who are pregnant, not for women who are breastfeeding. The way it works on the neurotransmitters like everything else. It works on the serotonin and the dopamine and the noradrenaline. It sort of works just like Abilify. Now when you compare it to other atypical antipsychotics, supposedly it has improved efficacy and tolerability and might not cause quite as much restlessness or quite as much insomnia. Or maybe it has nothing to do with that. It all depends on who you believe. Chemically, what happens is once you take the drug, about 95% is going to be absorbed, into the bloodstream maximum in about 4 hours. The half-life, once it gets in, takes about 91 hours to get half of it out. It's going to float around the bloodstream bound to proteins. It's going to be metabolized. And then 25% is going to be passed out in the urine, 50% going to be passed out in the stool. Interestingly, in female mice, not rats, but female mice, it can increase the incidence of mammary gland adenocarcinoma, breast cancer, by about 6-fold. Now, Otsuka really had a problem. You see, they also had the patent on Abilify, and the patent for Abilify expired in October of 2014, and generics came available in April of 2015, so that meant their revenue stream was going to take a big hit. So they brought out Rexulti in July of 2015 as a substitute or as a successor to Abilify. Recently, they've been spending millions of dollars to advertise the drug, and they're focusing on the lucrative market, the antidepressant add-on market. They talk about a brave phase and unresolved symptoms. They anticipate the revenue from the drug is going to be in excess of $1 billion, maybe $1.5 billion. But how do rating agencies consider the drug? Well, the medical letter, which is probably the most quoted research source, quoted drug source of information, says there's no reason to prescribe Rexulti over generic Abilify that's been around much longer and we know it's safe. They say also that you have to consider the cost. You can buy a month of Abilify for less than $25. You know how much a month of Rexulti is going to cost you? It's going to cost somebody more than $1,100 a month. Now, the Canadian government reviewed the situation as well. And the Canadian government, they said that for schizophrenia, there's not significant enough data, not sufficient enough data at the 4 milligram dose for long-term maintenance. And they said at 2 milligrams, it's not consistent. And actually, they said it seems to be pretty much the same as other antipsychotic drugs. So they say that the antipsychotic drugs shouldn't be used for non-psychotic depression. They said the trials are short. They're based on these rating scales, and we don't really know how to translate the rating scale to really how the patient is doing. And they say that the labeling camouflages the properties shared with the older antipsychotics. And then, of course, there's the problem of the increased risk of death in people who have dementia. So, just as an aside, in February of 2019, Rexulti failed 2 trials on mania. They were trying to get approval for bipolar disorder, for the mania of bipolar disorder, which is relatively easy therapy. Lots of drugs available. Well, they looked at patients who had mania severe enough to require hospitalization. So again, relatively easy kind of a treatment. But after therapy, the patients didn't seem to improve. So the company's excuse was the people who received the placebo did exceptionally well. Not the case necessarily. And now they're trying to get it approved for, or studying it for, hyperactivity in children, attention deficit hyperactivity disorder. And they were also hoping to get approval as the first drug for Alzheimer's disease, hoping that it would get licensed to treat the agitation of Alzheimer's disease. But they did 2 studies. One was positive and one was negative. And they have not been able to convince the Food and Drug Administration that it actually improved cognition in these people. The Veterans Administration puts up roadblocks to people getting the drug because they don't think it really is necessarily any better than the other medicines. And Medicaid, they say, hey, try the Abilify and the Risperdal and the Zyprexa and the Seroquel first, because these drugs are known quantities and they're relatively inexpensive. So if you're going to take Rexulti for 1 month of therapy, the cost is going to be somewhere between about $1,150 and $1,220 with a coupon. Now, they have all sorts of deals so that you can get the drug for less with a copay card, but somebody's going to pay a significant amount of money compared to Abilify for $22, Seroquel for $11 a month, Risperdal for $11, Zyprexa for $13 a month. Or remember, you could take the Rexulti, and you could take that for $1,100 to $1,200 a month. So where does the drug stand? It seems to be very unimpressive despite a lot of very slick advertising and heavy promotion. The drug company wants to continue the revenue stream, obviously, after generics of their Abilify have become available. But when we look at the scientific evidence behind it, is there any reason to use such an expensive drug? Does it really provide any significant benefit over what's already on the market, already on the generic market for very little money? And the answer is no, there isn't. And if you want to know more about some of these antidepressants or atypical antipsychotics, watch some of my other shows on them. Anyway, thanks for watching. I'm Dr. Ken Landau.
Thank you.